Hello, my name is Richard Jacques and I'm a statistician in the School of Health and Related Research at the University of Sheffield. Today I'm going to be talking about work I've done with colleagues in Sheffield on what impact did the introduction of NHS 111 Online have on the NHS 111 telephone service and wider NHS system. NHS 111 is a telephone and triage service for urgent but not life-threatening conditions. This service receives a high volume of calls, with approximately 15 million answered in 2017-18, and demand is expected to increase. In 2017, NHS England introduced 4 pilot NHS 111 online services as an alternative point of access for urgent care help. The online service allows users to use a web or app platform to enter their health problem and then answer a set of questions to get advice on what to do next. At the end of this session, a list of local services is provided. If needed, a callback from a clinician at the NHS 111 telephone service can be requested, or, where links allow, an appointment or callback from another service can be arranged. In 2018, this online service was expanded rapidly to cover all of England using a single platform based on the NHS Pathways triage system used by the 111 telephone service. The purpose of introducing the online system was to try to make the system easier and more accessible to users, and to try to reduce the number of calls to the 111 telephone service. Introducing a new system like this may reduce the demand for another service by redirecting activity, but there is also a risk that overall demand is increased by either duplication of service use or creating new demand. The primary aim of this study was to evaluate the impact of providing an NHS 111 online service to access urgent healthcare advice on the NHS 111 telephone service. The secondary aim was to explore the potential effects on the wider urgent care system and the implications of providing a national NHS 111 online service. The outcomes for the study can be divided into those related only to the 111 telephone service and those related to the wider urgent care system. The primary outcome was the number of triaged calls to the 111 telephone service following the introduction of 111 online. Triage calls are defined as any call that is assessed using the NHS Pathways triage process to determine what the health problem is, whether it is urgent, and provide a disposition advising what service is needed. This outcome excludes any calls which, for example, just provide health information with no assessment. As a secondary outcome, we looked at the total number of calls answered by the 111 telephone service. This includes triage calls, non-triaged calls for health information, and calls where the caller terminates before triage. Outcomes related to the wider NHS urgent care system were the number of emergency ambulance referrals or advice to contact 999, advice to attend an emergency department or other urgent care treatment facility, and advice to contact or attend primary care. The outcomes looking at the impact on the wider urgent care system comprised of the combined dispositions from both the telephone and online services. We collected data on 111 calls and online contacts between October 2010 and December 2019, and between January 2018 and December 2019 respectively. Our original plan was to request the telephone data at the individual level from NHS Digital, but at the time this was not available through the Data Access Request service. Instead, we used publicly available data on the number of calls from the NHS 111 minimum dataset. This data is in the form of monthly counts at NHS 111 area code level. Contacts with the 111 online service were provided by NHS Digital in the form of anonymous individual user sessions. As the telephone data is at an aggregate level, all analyses were conducted at the NHS 111 area code level. Our original plan was to investigate the 4 original pilot online services, comparing these to matched control areas. However, due to the rapid expansion of the service in 2018 and the availability of data, this was not possible. The telephone data was formed of records for 71 geographical area codes, whereas the online data was made up of STPs and CCGs. We were able to map the STPs in the online data to 38 of the NHS 111 area codes. The remainder could not be mapped due to the STPs and area codes not being coterminous, and due to changes in health geographies over time. Our plan required a full year of NHS 111 online data. Therefore, we had to exclude any areas where the service hadn't been operating for at least 1 year. In total, there were 18 areas remaining for the analysis. These are highlighted on this map. Each of these areas had a minimum of 36 months of data, 24 months of 111 telephone data before the introduction of the 111 online service, and a minimum of 12 months online and telephone service data after the introduction. We used an interrupted time series approach to model the impact of introducing the 111 online service. In conventional interrupted time series, the number of calls will be modelled as a function of time after the introduction of the online service. However, we used an alternative dose-response approach where the number of calls was modelled as a function of online contacts. This dose-response model provides an estimate of the reduction or increase in the number of telephone calls per online contact. The outcomes are all count data, so we use negative binomial models to allow for over-dispersion. In this plot, the solid dots are the number of calls to the 111 telephone service for each month, and the hollow dots are the number of contacts to the 111 online service. The solid line is from the interrupted time series, and the dashed line shows the model if there was no intervention. So in this model, there appears to be a reduction in calls after the introduction of the online service, and using our model, we can quantify that reduction per online contact. Each area had a different start date for the introduction of the 111 online service, so we modelled each area separately and then combined the results using a random effects meta-analysis to estimate the average effect of introducing the online service. Here we have the results of the primary outcome of number of triage calls to the 111 telephone service. This forest plot shows the estimate and 95% confidence interval for each of the 18 111 areas included, and the combined overall estimate from the random effects meta-analysis. The x-axis is showing the incidence rate ratio per 1,000 online contacts. The overall estimate is 1.013. This means that on average for every 1,000 online contacts, the number of calls to the 111 telephone service that are triaged increased by 1.3%. The 95% confidence interval around this effect is minus 0.4% to 2.9%. So overall, this shows that there was very little impact on the number of triage calls. This secondary outcome looks at all calls to the 111 telephone service, reflecting how many people attempted to contact the service. The overall incident rate ratio per 1,000 online contacts is 1.008, suggesting that on average for every 1,000 online contacts, the number of calls to 111 increased by 0.8%. The 95% confidence interval for this estimate is minus 0.8% to 2.5%. This suggests that the introduction of 111 online has had little impact on the total number of calls. The results so far have focused on the impact on the 111 telephone service alone. The remaining results will look at the impact on the wider NHS urgent care system. This first outcome is the number of 111 telephone and online contacts with a disposition of recommend an emergency ambulance response. Within the telephone service, this is facilitated by 111 sending the request directly to the local ambulance service. For 111 online, the disposition advice is to call 999. The overall incidence rate ratio per 1,000 contacts is 1.067. This means that on average, for every 1,000 online contacts, the number of ambulance dispatches potentially increases by 6.7% if all online contacts follow this advice. The 95% confidence interval for this estimate is 3.5% to 10%, suggesting that the online 111 service has the potential to result in an increase in the number of ambulance dispatches overall. These results are for the outcome of recommendation to attend ED. As with the emergency ambulance outcome, this is the total number of recommendations from both the telephone and online services. The overall incident rate ratio per 1,000 contacts is 1.05. This means that on average, for every 1,000 online contacts, the number of recommendations to attend ED has increased by 5%. The 95% confidence interval for this estimate is from 1% to 9.2%. This result suggests that on average, the 111 online service has caused an increase in the number of recommendations to attend ED. The final outcome looks at recommendations to either speak to or attend primary care. This excludes recommendations to contact a pharmacy or dentist. The overall incidence rate ratio per 1,000 contacts is 1.051. This means that for every 1,000 online contacts, the number of primary care recommendations increases by 5.1%. The 95% confidence interval for this effect is 2.7% to 7.6%. This result suggests that on average, the 111 online service has increased the recommendations to either speak to or attend primary care, and this has a potential to increase the number of primary care contacts overall. There are some limitations to these analyses. Firstly, due to the rapid rollout of 111 online as a national service, we were not able to use an interrupted time series design with a control arm. This means any effect seen cannot be assumed to be the direct result of introducing the new service. It's possible they may have happened anyway due to other factors impacting on both the 111 telephone service and the wider emergency and urgent care system. Secondly, the available data limited our analysis to 18 areas, and therefore we were not able to estimate the impact of introducing the service nationally. However, the areas included are representative of different geographical areas, activity volume, and provider types across England, so we believe our inferences are reasonable. Thirdly, this evaluation was conducted at the early stage of implementation, with sites being in operation for 12 to 18 months. Analysing the data at a later stage when the service is more widely understood by the public may make the evaluation more robust, although the impact of the COVID-19 pandemic would now make further evaluation difficult. Finally, the outcome for the wider emergency and urgent care system are recommendations for care and not care received. This makes it difficult to estimate how much new demand there would be. One possible way of addressing this would be to do a study linking data to different services. In conclusion, NHS 111 Online had little impact on the number of triaged and total calls to the 111 telephone service, suggesting that the workload for NHS 111 has not increased nor decreased as a result of introducing the new service. There is some evidence of an increase in the overall number of disposition recommendations to the ambulance service, ED, and to primary care. However, as these are recommendations, it is not possible to say whether this will have actually increased demand or workload for these services. In future, it will be important to monitor the impact of increasing NHS 111 online use and avoid creating larger volumes of new demand in a system that is already under pressure. Thank you for listening. If you have any questions or comments, please contact me at this email address and I will be happy to respond.